Let us now move on to the next session for the day. Recently, the field of oncology has witnessed a remarkable shift towards precision medicine, particularly in the management of lung cancer. Precision medicine offers a tailored approach to treatment, leveraging insights from molecular profiling to identify the most effective therapies for individual patients. This paradigm shift holds immense promise for improving outcomes in lung cancer patients by optimizing treatment selection and minimizing adverse effects. Today, our panel will explore the current state of precision medicine in lung cancer management, its impact on patient care, and the opportunities and hurdles in realizing its full potential. And with this, let me introduce you all to the topic of this panel: Precision Medicine Paradigm, Transforming Lung Cancer Management, with session partner Pfizer. And now, I'd like to welcome our speakers for this panel to join us on stage. Please welcome them with a huge round of applause. Dr. Manish Singhal, Senior Consultant, Medical Oncologist, Apollo Hospitals. Dr. Jyoti Wadhwa, Vice Chairperson and HOD, Medical Oncology and Hematology, Paris Hospitals. Dr. Sanjay S. Rai, Head of Department, Medical Oncology, Employee State Insurance Corporation, Faridabad. Dr. Anushka Amlani, Team Voice of Healthcare. Dr. Singhal will be joining us in a couple of minutes. And now, I hand it over to you, Dr. Amlani.
Thank you, Dr. Tarini. Good afternoon, everyone. I'm Dr. Anushka Amlani. On behalf of Voice of Healthcare, I thank you for your presence today on Precision Medicine Conclave and Awards 2024. Patient heterogeneity was a nuisance for evidence-based practice, but it is a blessing for precision medicine. Having said that, precision medicine, often known as personalized medicine, has proven to be a breakthrough in recent times. With its vast scope and scientific credibility, it is replacing traditional therapies very quickly. Today, we are honored to have our esteemed group of panelists, Dr. Manish Singhal, who will be joining us shortly, Dr. Jyoti Wadhwa, and Dr. Sanjay Rai, to delve deeper into the realms of precision medicine and how it has and continues to transfer lung cancer treatment management. Before we begin with the discussion, I would like to ask the very talented doctors on stage today to reflect and share their thoughts on the following questions. Dr. Jyoti, how do you think precision medicine has been helping you in your daily practice? And what was your first experience in treating lung cancer patients by applying precision medicine?
Right. So, very important and interesting question for me. So, if I share with you all that I've seen the treatment of lung cancer evolve from my MD days to now, when I'm a full-fledged medical oncologist in 2024. So, during my MD medicine training at AIIMS Delhi, because my head of the department was a pulmonologist, therefore, I did have some experience of dealing with lung cancer patients, even then, way back in 1993. So in that time, we had very few drugs to deal with advanced lung cancer patients, namely cisplatin and cyclophosphamide, methotrexate. However, times changed soon, and during my DM training, we had a few more drugs, namely taxanes, which did make a mark and did improve the outcome of these lung cancer patients. And subsequently, during my period as a consultant in medical oncology, what has changed is that till 2008, and I did mention in the previous session, the decision was based on the histopathology report. However, something happened in 2009 with the identification of EGFR mutation, and even before, about a few years before, that the alterations, the genetic alterations started to get identified for lung cancer patients mainly non-small cell lung cancer patients and mainly adenocarcinomas. So EGFR and then the EGFR targeted therapies, and we now have different generations of these treatments. First generation, second, third generation of EGFR targeted therapies. We subsequently in 2011 identified the ALK, EML-ALK gene rearrangement, and since 2013 we have had ALK inhibitors, and subsequently we have seen the ALK inhibitors also evolve, the first generation, second and third generation, with each new advancement leading to better, more efficacious drugs, more penetration into the CNS, and therefore more or better intracranial control, and so on and so forth, when now we talk of at least 10 targeted therapies just for lung cancer being available for use even in India, wherein we have been able to identify the driver mutations, and we are able to offer the precise targeted therapy, and which have led to a better survival, better response rates, and better quality of life. So all these targeted therapies have been found to be superior to the then standard of care chemotherapy drugs. Another new advance which has happened is the immune checkpoint inhibitors, which have revolutionized the cancer treatment, not only for lung cancer, but for so many other cancers. And in fact, the identification of this phenomenon led to the scientists getting Nobel Prize very recently. So the immune checkpoint inhibitors are a beautiful way of treating cancers. So you are, unlike chemotherapy, which would go and directly kill the cancer cell, here you are harnessing your own immune system, immune cells, to get unlocked with these drugs and go and attack the cancer cells. So that's just see the beauty, how we are, how well we have been able to identify the biology of cancer, how we have been able to dissect at the molecular level, thanks to the advances in the molecular biology. And we now work as a bigger and better team. So it's not just the medical oncologist. You would know there are at least 8 other teammates to this, starting from pathologists to molecular oncologists to surgical and radiation oncologists. And inputs from all these are so very pertinent, and it's no more just my domain to treat even stage 4 lung cancer. So that's how the times have changed.
Thank you so much, ma'am, for your insight. Dr. Sanjay, how has your experience been?
Yes, I started treating lung cancer since about 23 years. And that was the time when even if some FNAC is done and it comes positive for malignancy, we start treating with chemotherapy drugs. And some of drugs today we say that those drugs really don't work. So how things have changed. Later on came the era of microscopy, when we have to classify the lung cancer according to histopathology. Then we have to treat accordingly, like squamous, adeno and all these things. Then now we are in an era where nearly 2008 or 9, we started treating according to EGFR mutations. So there was great hope with this, because without giving chemotherapy, it's just a single drug, and patient don't have to come frequently, and very less side effects. There were first generation EGFR inhibitors. Then came the era of ALK rearrangement. Then subsequently 7-8 more biomarkers. So now it is as per guidelines. First, when you get a carcinoma lung patient, which is non-small cell, then it's mandatory to do biomarker or molecular testing. So accordingly, then you plan your treatment. Thank you.
Thank you, sir. Moving on with the panel discussion, my first question is to Dr. Jyoti. Ma'am, as a medical oncologist, how has the integration of precision oncology changed your approach to treating lung cancer patients in your daily clinical practice?
So, unlike earlier, when we had only chemotherapy, now since we have many more options, so we have to be more careful as to what to offer to a given case when. So the impact of these precision medicines have not only now been restricting to stage 4 lung cancer, we have seen them help our even earlier stage lung cancer patients live much longer. So they have initially found their place in patients with metastatic lung cancer or stage 4 lung cancer, but now we have moved to stage 1B, 2, and 3, even before surgery, the neoadjuvant role, even after surgery, the adjuvant role. And there is also a role for adjuvant immune checkpoint inhibitors as well after, say, concurrent chemoradiation for stage 3 disease. So now, coming to stage 4 patients, lung cancer, the precision medicine has to be, it has to be evidence based. So you have to do at least a basic number of gene panel, which we do offer to all our patients. So 100% of the patients are now able to afford and therefore undergo at least that minimum 12 gene panel, lung panels, along with PDL1 testing. So that's 100%, which is quite a remarkable achievement given the financial constraints for a vast population of ours. So then, depending on a case, if the patient can wait for the result to come, we nowadays don't run into giving the chemotherapy. If the patient's condition or tumor burden is such that the patient can wait, because we know the superiority of these targeted or specific precise treatments over the conventional chemotherapy, so we tend to wait. However, if we can't wait for the report to come, we do start with the chemotherapy even now. And then, as and when, and depending on the response to the chemo received till then by the patient, we modify our plan. So, targeted therapies, immunotherapies have now become integral part, because we know that almost 40 to 50% of these stage 4 lung cancer patients would be eligible for one of these targeted treatments. So that's quite a high number, and therefore they must be given this benefit.
Thank you, ma'am. Dr. Sanjay, can you please tell us the most common genetic mutations targeted in lung cancer and the corresponding therapies available for each?
See, there are two kinds of genetic mutations in lung cancer, and that is predictive as well as prognostic. So if you say prognostic, it means that only tells how aggressive is your disease. So KRAS mutation is one which is actually common, very common, but that is prognostic. If you say predictive to therapy, EGFR mutation, which is more common in our Asian populations, and we have good drugs for that. There are first, second, and third line generation. So almost 6-7 drugs are available. Just a tablet, oral tablets, where various dose schedules are there. And there are some drugs amongst these which can penetrate even your brain, like CNS penetration is very high. So in lung cancer patient, common problem is failure inside brain. And when disease goes inside brain, the life expectancy comes down automatically. So these drugs, when they are penetrating the brain, it means progression inside brain will be less. Hence, there will be more increased life expectancy, like we expect beyond 2 years also. So that is that we are seeing in our routine practice.
Thank you so much, sir. Dr. Jyoti, how do you determine the eligibility?
I can see Dr. Manish join us.
Thank you, sir. Thank you for joining us, sir. So I think I'm going to ask my next question to Dr. Manish, not give him much time to warm up. Sir, how does targeted therapy differ from traditional chemotherapy in terms of effectiveness, particularly in the context of lung cancer treatment?
So I think, simply put, the target therapy only performs if the target is there. There's no target, the target therapy doesn't perform. Vis-a-vis chemotherapy, if I were to say it very simply, it doubles the response rate to therapy. If chemotherapy performs in 30 to 40%, it will be like 80%. The depth of response, that means how much tumor reduction you achieve, is also almost doubled up. The duration of response is doubled up, or maybe even tripled, and sometimes it is 5 times higher. And the toxicity is reduced to half. So you are in a gaining position this way or that way.
Okay. Thank you so much, sir. Dr. Jyoti, ma'am, how do you determine the eligibility of a patient for targeted therapy, and what are the diagnostic tests that are typically conducted to identify suitable genetic markers in lung cancer cases?
Right. So nowadays we prefer broad panel NGS testing. And as I mentioned, the number of genes could vary. There could be, a limited number of genes. As I mentioned, at least 12 gene lung panel along with PDL1 test is the minimum that we do. But the it could be much more bigger gene panel, and more the number, we may be able to identify a greater number of genetic alterations, but we have to also know as to what we do with those, so some of it is known, but a lot of it is research in progress. So we have to keep that in mind. And if we are able to, based on the comprehensive genomic profiling, we are able to identify a particular driver mutation, then we offer that specific targeted therapy. So, as we just learned, that EGFR mutations are the most common, and almost 30% of even our Indian adenocarcinoma patients could be harboring one of those EGFR mutations. Then there are other genetic alterations, say ALK or ROS, and HER2 or RECT, MET, and there are BRAF. So all these genetic alterations, if identified, have targeted therapies available. And also we have some other alterations against which we do not have any targeted therapy proven as yet. But we are aware, and sometimes it's good to know their presence as well, because that could also help in decision making. In addition to these genetic alterations, very important to know the PDL1 status. And as I mentioned, we have immune checkpoint inhibitors. But one thing to keep in mind is that if we are able to identify any of those driver mutations, the best way forward would be a targeted therapy, and not even immunotherapy or chemotherapy. So that's why it's so very important to identify those driver mutations.
Thank you, ma'am. Dr. Sanjay, so from a patient's perspective, how does the availability of targeted therapy impact treatment decisions? And with advanced metastatic lung cancer, what role does it play in the overall treatment plan?
When these things were not available, with chemotherapy, we could hardly get a life expectancy of 6 months to 1 year, sometimes 14 months. But if we can identify target within tumor, and we have drug for that is called actionable mutation. So with that, I told earlier also, it goes beyond like 16 months, like 2 years. So that is always good, increasing life expectancy for the patient. And in fact, side effect is also less, toxicity is less as compared to chemotherapy. So overall, patient's quality of life, it improves. There were concerns earlier regarding finances, but we have both group of drugs now, newer targeted therapies and older ones, which India is also manufacturing, Indian companies. So we have lesser priced drugs also, and we have newer drugs which are always like patented and higher price. So we have options for both the group who can't afford much. So this is a good thing. Yeah.
Thank you so much, sir. Dr. Manish, what are the most common mutations seen in non-small cell lung cancer, and how do they influence treatment decisions?
So I think it's almost a similar question to what ma'am just answered. So I think the most common is EGFR mutation, which I think would be about 30% of our patients. This is followed up by ALK mutation, which is around 5 to 7%. Thereafter, it is the BRAF mutation, which is around 2% to 3%. Then the ROS1 mutation, which is around 1%. There's a HER2 mutation, which is again around 1%. There's a RET mutation, 1%, and there's a MET mutation, which is around 5%. So I think cumulatively about 60 to 65% of never smoker, that's another reason not to smoke, and then you are more likely to have a target. 65% of never smokers would have some target or the other. It's relatively lesser common to have a target if you're a smoker and you still get a lung cancer. So never smokers, they are more likely to have a target, and therefore the target therapies are generally meant for never smokers. So, and the therapies, if you have a target, then you have the liberty of choosing your first line therapy or the first generation drug to second generation drugs. So much so that for each target now we have generations of drugs. Of course, the first generations are out of patent, they're very cheap. Second generation are also out of patent. Third generation is still under patent, so they're expensive. But of course, the third generation would work better than the first generation and would have lesser side effects, more efficacy like that. And we are moving. We are still moving. We are becoming better with every passing day.
Thank you, sir. Dr. Jyoti, ma'am, what are some specific targeted therapies available for the patients with ALK mutations, and how do they differ from standard chemotherapy?
So as Dr. Manish just said, that even for ALK inhibitors, we have different generations of the targeted therapies. So it all started with the availability of crizotinib way back in 2013. It was identified then, 2010, 2011, the EML-ALK gene rearrangement, and then we had the drug available for use in 2013, crizotinib, and then we had ceritinib, and now we have even better drugs, the third generation. So we have drugs like lorlatinib, alectinib, brigatinib. So with each new generation, we have been able to improve the efficacy both intracranially and extracranially, tumor control rates. All these drugs have their own set of toxicity profile, and we as practicing medical oncologists need to be aware, and when we give, so we know what to expect in terms of not only the response rates or efficacy, but also the side effects, and we have to warn our patients as to look out for this, when to dose reduce or when to stop. There are guidelines in place. So these are the different ALK inhibitors, and so much so that if they have, say, brain metastasis, we even have the liberty now to not, so if the patient has brain metastasis found on MRI, the brain imaging, we may not even offer them surgery or radiotherapy. The drugs are so much better now that they have significant intracranial penetration, and they just these tablets may be enough to take care of even that brain metastasis. So we have to individualize as to whom to offer just the drug or add on some local treatment. But we have reached there, when we have drugs which are much more effective, the ALK inhibitors.
Thank you so much, ma'am. Dr. Sanjay, in your experience, sir, what are some key factors that influence the prognosis and treatment outcomes for the patients with ALK mutations?
See, in all stage 4 lung cancers having ALK mutations, performance status is one issue. If the patient is having PS3 or 4, so that is like lesser, for prolonged term, there is lesser benefit in terms of patient is already weak because of tumor. Second thing is comorbidities. There are like liver dysfunctions or cardiac dysfunctions. So using TKI sometimes may be difficult. They may have more toxicities, and otherwise finance is an issue, and that is a issue like I told, there are drugs, older drugs, which can use for patients who are financially challenged, but patients who are insured, they can be put on newer drugs like lorlatinib, which have better efficacy in terms of penetration to CNS, brain, and that's all.
Thank you, sir. Dr. Manish, So, how do you monitor treatment response and disease progression in patients receiving ALK targeted therapies? And what imaging or biomarker tests are typically used for this particular purpose?
Yeah, so I'll break this answer into two parts. One is understanding the toxicity, which I think Dr. Sanjay has very rightfully said. I think the first and the foremost is toxicity management, because most of the toxicities will surface itself in case they do surface in the first 1 month. So I think the first 1 month to 2 months is toxicity management. Once the patient has stabilized and there's no such toxicity, then comes the response evaluation. So we generally do a PET CT scan. That's the basic step to do any response evaluation. So simply put, the like has to be compared with like. If you've done a CT scan, you got to do a CT scan. If you've done a PET CT scan, you got to do a PET CT scan. ALK positive lung cancer has predilection to go into the brain for some reasons or the other. We don't know why, but about 30% patients of ALK positive lung cancers will have brain metastasis. So it's very important to see the brain. And as ma'am said that, the current ALK inhibitors such as lorlatinib have such great activity in the brain that the tumor just vanish away. You don't see the tumor. And you don't require any radiation therapy or nothing. In yesteryears, when there were no ALK inhibitors, we used to do radiation therapy to the brain. So patient used to get better, but then the fallout of radiation used to surface itself. Patients used to have neurocognitive dysfunction, bhul jate the, yaad nahi rehta tha, they were not able to take care of themselves. So cancer theek ho gaya, but comorbidities बढ़ गई. But with the current ALK inhibitors, there's no comorbidity, the cancer just vanish away. It's like vanishing tumor. And this keeps on happening for year after year, year after year. I remember it was in 2018 or 19, just before the COVID, that the international patient assistance program was started for lorlatinib, which is an ALK inhibitor. And it was free program. So we used to enroll our patients totally free of cost. Those patients are still doing well. We are sitting in 2024. They used to have brain metastasis, they had florid disease, there was no hope. And they are just on one pill a day and they're doing well. There's no evident disease in the body. So this is the magic of science.
Thank you so much, sir. My next question is to Dr. Jyoti. Ma'am, how common is the EGFR mutation in lung cancer patients today? And what percentage of lung cancer cases typically exhibit this mutation?
So, EGFR mutations are the most common mutations identified in non-small cell lung cancer and more so in adenocarcinomas. However, it's important to know and therefore order the NGS test even in non-adenocarcinoma lung cancer, especially those who are never smokers or are reformed smokers. They left smoking many years ago. And even in them, we could still be able to find this mutation. So if we talk of adenocarcinoma, non-small cell lung cancer, the frequency of EGFR mutations varies from in different geographic locations and based on the ethnicity. So it can be as low as 15%, say in West in USA, to say 30% in India, and it could be as high as 55% in the East, Japan, Korea, that China, that part of the world. So the frequency varies, but it's significantly high to be addressed and such patients to be offered the EGFR targeted therapies.
Thank you so much, ma'am. My next question is to all panelists. Can you please share some inspiring patient stories of lung cancer with overall survival has increased by targeted therapy? Dr. Manish.
There are multiple such stories. I'm not able to recall which one to tell, but I think they're multiple, and we have witnessed so many of them. And I think the good thing is that we are just getting better with each passing day. There are newer drugs coming in, and it's a very welcome move that science is, advancing in that manner. When the first generation came in, patient used to progress in about a year's time. For example, in EGFR mutation, even for the ALK mutation. But then we understood that what is the mechanism by which the cancer is progressing? What is the mutation which is happening? Then they made a drug for that particular mutation. Then they got a drug which could not only counter the basic mutation, but the mutation which they are likely to become resistant with. So I think with such understanding of the molecular aberrations in the tumor, newer drugs are being formed and better drugs are being performed. Not only this, they're making drugs which have lesser side effects also. So as I said that we had a patient who had ALK mutated lung cancer, and we were happy to get patient enrolled into a patient assistance program, because cost is always a barrier in India, and the patient is still getting the drug totally free of cost. Of course, it is the great heartedness of the company which produces it, and they're still, despite the drug being available in India now, being marketed in India, they're still getting it totally free of cost. And it has been 5 years down the line that there is no speck of disease evident in the PET CT scan or in the MRI brain. The patient had a brain metastasis. And so there are not one, there are multiple such stories. There was a young lady, chartered accountant, started her treatment way back in 2014. We did chemotherapy. There was no mutation found at that point in time. So whatever panel we used to do in 2014. Then she recurred, we changed the chemotherapies, etc. Then we thought that let's do another set of mutation. Now there are newer drugs. We did another mutation, we got a BRAF mutation. Again, it is a Novartis molecule, and we applied for Novartis patient assistance program. We got the drug totally free of cost. Finally, the cancer was gone. We lost the patient to COVID, but not cancer. So, there are multiple such stories. I'm sure ma'am would also have some.
Yeah, when this EGFR mutation drugs came, and this theory was very strong that it is more common in women and less smoker or non-smokers. So it was in 2010, one 80-year female was shifted under my care. Patient was breathless, on oxygen, having bilateral fluids in lungs like pleural effusion, and there was chest mass. It was like pleural effusion was positive for malignancy. So since patient was sick and elderly lady, relatives, they wanted to take her back to Uttarakhand. She was from Uttarakhand, and that time we do as a clinician do some creativity also. When this concept was there, non-smokers and women's EGFR mutation may be there. So even without doing testing, I said, okay, take this tablet. I started one minimal erlotinib tablet was started, and that lady came after 6 months, walking and smiling. So I was surprised because, I thought she might have been no more. So this was a great thing. Then I expected she might be harboring EGFR mutation. I don't know, but her lung was clear at that time. I did another testing, but lung was very much clear. So these are like rewarding drugs with this target therapy and precision medicine. And we are happy to say that as oncologists, we are pioneers in many things. We are pioneers of newer antifungals, newer antibiotics, newer kind of therapies, newer ways of therapies. So we test everything, and then it comes to other branches of medicine. So that's a great story with precision medicine.
Thank you so much, sir.
Two interesting cases that now come to my mind, and let's talk about just the ALK gene rearranged non-small cell lung cancer. So one patient that I have, he has been on crizotinib, the first generation, since 2015, and he continues to be in complete remission and takes just 2 capsules a day of crizotinib. So it's 2024. He comes just once a year now for follow-up and for imaging to me, and he's doing great. He has been able to celebrate his golden marriage anniversary, and he has married off his grandson just last year, 2023. Very happy, is getting it free of cost again, and is enjoying a great long life and great quality of life. The other patient, very interesting, 19-year-old boy who had come to me from Iraq, and he had very extensive brain, skeletal, and including malignant pericardial effusion. He was in cardiac tamponade and miserable in cardiac ICU. And he was diagnosed, and obviously lung mass. He was diagnosed with ALK positive non small cell lung cancer. I've been treating him since 2019, and he is doing very well on just a tablet a day in complete remission. He wants to now get married, and he plays football and very well. So, and the other last story, another person again from Iraq, a sports teacher, a physical education teacher who takes just one lorlatinib, and you can't make out, these both the all three of them, they don't even look like any patient now, and they have been they are blessed, and they have taken the full benefit out of the targeted therapy. So that's the beauty of these targeted treatments, and doing great, enjoying very good quality of life. And he is back into action, and he continues to train other children in the school where he works. So,
Thank you so much. My next question is to Dr. Manish. So, how has the advancement in tertiary care penetrated into tier 2 and tier 3 cities? How are we able to get precision medicine and the application of it to those cities, or is it just in the tier 1 cities?
I think there was a time when these advancements could not reach tier 2 and tier 3 cities. But now things have changed. And much is attributable to the availability of experts. There was a time when there was hardly, when I did my medical oncology, All India Institute of Medical Sciences, there were total 14 seats. I'm sure, ma'am, आपके टाइम पे तो और भी कम होंगी शायद. There were only 14 seats all India to do DM medical oncology, and now perhaps there are more than 200, maybe even more. So we have now medical oncologists reaching into tier 2, tier 3 cities, and thankfully I think patients coming from such cities or such townships would also get the best of the care, and they're all well educated, well trained people who are offering their services, because what the mind doesn't know, the eyes doesn't see, as simple as that. So you got to know things. If you know things, then you are able to provide the best possible care. And thankfully, I think testing has become cheaper, drugs have become cheaper. Whenever I take a CME with a physician forum, I ask them, okay, last time when you saw a diabetes patient, how many drugs did you prescribe? 1, 2, 3, 4, 5. कहते हैं यार एवरेज 4-5 तो हो ही जाती है, रोजोवास्टेटिन भी देनी है, कुछ इंसुलिन भी देना पड़ेगा, एटसेट्रा एटसेट्रा. मैंने व्हाट इज दैट एवरेज एक्सपेंडिचर ऑफ दीज ड्रग्स for a month? They say that around 3 to 4,000, maybe 5,000. I will prescribe for lung cancer just one tablet, and it will be 2,500 rupees a month. How does that sound? So it's like that. So I think if everybody cannot go on to the third generation drug, but the first generation drug is not that bad also, and it's very cheap. So I think the benefit of science should reach everybody, and I think it is reaching. What do you say, man?
yeah, definitely. Definitely, the penetration has increased, not only in terms of, we have patients all over. The disease doesn't distinguish, as to whom to affect. It can affect all of us are at risk. Anyone can suffer from cancer. And now with the increase in these seats and DM and DNB programs running in the entire country, many more medical oncologists, radiation oncologists, and surgeons getting trained, I think the situation is much, much better now.
Tier 1, 2, 3 city doesn't differentiate. It's the financial constraints. So there are various ways of testing for mutations, genetic mutations, like immunohistochemistry, PCR, FISH testing, NGS, which is more broad. So if patient is having less finances, we go for cheaper test, targeted mutation testing, like PCR, to identify only common mutations like EGFR or L. But if finance not a constraint, we go for more broader profiling. But that is also that creates confusion also. We get more mutations which doesn't have medicines to offer. Plus sometimes you don't know the significance of getting additional mutations. Sometimes you get double mutations in broad molecular testing. So you are also confused whether how to interpret and how to go ahead, whether this drug will work or not. There are challenges.
Thank you so much, sir. I thank all the panelists for their wonderful insights, and I request you to kindly give a closing remark.
So I think lung cancer has seen a sea change in what we were about 1.5 decades back and what we are now, and we are just improving with every passing day, as I said, and the science is progressing, and I think there is a lot of hope. Of course, less has been done as far as prevention of lung cancer has been done. And now time has come that we start focusing on prevention of lung cancer. And I always maintain this. I know I'm hated for this, but then air pollution is one of the leading causes of lung cancer. WHO identifies it. IARC, International Agency of Research on Cancer, has labeled particulate matter 2.5 as a known proven carcinogen. We are sitting at 100, 200, which is okay for us. The WHO safe limit is 10. France published their results where the AQI is around 25, that with every increase from 25 and above, there is a linear relationship with the incidence of lung cancer. We are not doing any justice to the younger generation that we are breeding. It's a very serious matter. I don't know why our politicians, our policy makers don't pay any heed to it. We are sitting on a time bomb, and it's scary.
So I fully concur with Dr. Manish. For all diseases, including cancer, prevention is better than cure. But unfortunately, that aspect of lung cancer continues to be neglected, both in terms of tobacco cessation and also now the AQI, the air pollution in Delhi NCR, the levels above 200 and above 400 during winter months has been accepted as a norm, which is so very wrong. So, we agree that we are practicing as medical oncologists in very exciting times. We have better treatments now available, which are much better than what we had a few years ago. Patients are surviving lung cancer now, living a much better quality of life. But it's our responsibility, as well as the public health experts and government's responsibility, to look into and enforce the relevant laws, looking at the prevention aspect also of lung cancer. Otherwise, we are just moving forward and not, and the incidence is also increasing, and some reduction in mortality happening with these newer treatments. The ultimate gain may not be much then, if we don't put our focus also on the prevention.
Thank you, ma'am. Dr. Sanjay?
I think Voice of Healthcare should take up this theme of prevention and screening in cancer also. And precision medicine has got a great future in oncology. And that also, we are also very happy, that makes us more important, because we are able to interpret the reports and give targeted therapies and better results. So we are also happy with this development. Thank you.
Thank you so much.
I'd like to thank our panelists for this discussion. I'd also like to thank Dr. Amlani for wonderfully leading this discussion. Now, I request Dr. Amlani to felicitate her co-panelists. Dr. Manish Singhal. Dr. Jyoti Vadhva. Dr. Sanjay S. Rai. I'd also like to invite Dr. Manisha Kurhana to felicitate Dr. Amlani. Dr. Anushka Amlani. I'd like to request the dignitaries to stay for a group picture.